Hi all, and welcome to Professor Truelove's Concepts for Nurses series, and I am Professor Terry Truelove. In this episode, part of the Orthopedic Nursing series, we will look at osteoarthritis, or OA, assessments and interventions. Sources for this episode include Iggy's Medical Surgical Nursing, 9th edition, and Soul's Introduction to Critical Care Nursing, 7th edition. Rheumatology is a medical specialty in which connective tissue disease, or CTD, is the major focus, and it focuses on both non-inflammatory or inflammatory processes. Rheumatic disease means any disease or condition involving the musculoskeletal system, and you should know that arthritis simply means inflammation of one or more of the joints. The most common CTD is osteoarthritis, abbreviated as OA, basically caused by gravity. OA is the most common arthritis type and is caused by the progressive loss of cartilage. It is manifested by joint pain, loss of function, and is characterized by progressive deterioration. That means it gets worse over time. Other hallmarks include the presence of osteophytes, or bone spurs. Over time, the cartilage disintegrates, bone and cartilage float into the joint, causing crepitus, or noisy movement at the joints. This is the cracking and popping that you can sometimes hear. For the assessment of OA, you should know that the patient experiences joint pain that diminishes after rest and intensifies after activity, a great way to differentiate from RA. As the disease progresses, pain occurs with even the slightest movement, and at times even with rest. The symptoms are aggravated by temperature changes and climate, particularly humidity. Look for the presence of Heberden's nose or Bouchard's nose. The patient with OA will have joint swelling, crepitus, and limited range of motion. They will have difficulty getting up after prolonged sitting. They will complain of morning stiffness. You will note skeletal muscle disuse atrophy, particularly in the affected areas, leading to the inability to perform ADLs, and even the compression of the spine, causing loss of height. Other assessments include assessing the psychosocial status of your patient, because the severe pain may cause depression and/or anxiety, to do a laboratory test for both a erythrocyte sedimentation rate, or ESR, or an hsCRP, that is a high sensitivity C-reactive protein level. Look for radiographic changes, which will show the bone deformities. Other diagnostic tools include MRI and CT studies, again, to look at the anatomy of the body. So, collaborative management includes obtaining a history. Note that the patient will usually be older than 60 years, but that arthritis strikes even younger ages. Look for the physical assessment and clinical manifestations of joint pain and stiffness, crepitus, Heberden's nose, Bouchard's nose, joint diffusions, that is, water within the joints, and atrophy of skeletal muscles. Non-surgical management includes the treatment of the chronic pain by drug therapy, rest, immobilization, positioning, thermal modalities including hot and cold packs, decreasing weight, particularly if the patient's complaining of pain in the knees, and integrative therapies including but not limited to supplements such as glucosamine and chondroitin. Interventions for OA pain include NSAIDs, muscle relaxant, and other meds. There can be corticosteroid injections into the joints. You should position the joints in functioning positions to avoid flexion of the knees and the hips. You can immobilize the affected joint with a splint or brace until the inflammation subsides, and try to avoid large pillows under the head or knees, which causes too much flexion or extension. Other interventions include providing a bed or foot cradle to keep the linen off the feet. You should instruct the patients of the importance of moist heat, hot packs or compresses, and even paraffin drips. You should teach to apply cold applications as prescribed when the joint is acutely inflamed, and encourage adequate rest. Recommend up to 10 hours of sleep at night, and a 1 to 2 hour nap in the afternoon. Surgical interventions for OA is to reduce the chronic pain, and they can include total joint arthroplasty or even total joint replacement. The total joint replacement is performed when all measures of pain relief have failed, including the arthroplasty or the repair of that joint. Replacement is most common in the hips and knees. TJR is contraindicated in the presence of infection, in the presence of advanced osteoporosis, or with severe joint inflammation. Sometimes the repair can be done through a scope called an arthroscope, and the procedure is called arthroscopy. And sometimes an osteotomy is required. This is a shortening or lengthening of a bone to realign it. This realignment has been known to reduce joint stress and therefore reduce pain. Knee and hip replacement surgery is very painful and complicated, so collaborate with the patient and family to become safety partners to prevent complications such as hip dislocation, thromboemboli, infection, anemia, and neurovascular compromise. Frequently, the OA is caused by being overweight, so nutrition should be addressed. The nurse should encourage a well-balanced diet and tell the patient to maintain weight within normal ranges to decrease stress on the joints. And that does conclude this episode. However, stand by. There are more episodes to be viewed and listened to. So, I hope you learned something today. I hope you plan on coming back and listening some more, and if you are, we'll see you then. Take care.